So you're in Bergamo in Italy, is that right?
Yes. So I'm working in Bergamo, and our ophthalmology department is based in Bergamo. And so, as you know, probably is the epicenter of the Italian, COVID-19 outbreak. So
Right.
the situation now is getting a little bit better.
So as an ophthalmologist, did you find yourself still in a position where you were performing ophthalmic surgeries, or were you starting to convert into more of a an emergency medicine specialist helping with the cases of COVID?
Okay, now we are trying. So we had, a period where the ophthalmology was completely closed. So we didn't see any patient, we didn't do anything because our hospital was full of COVID-19. So all the effort was just for them. Okay. And so this is and we tried to help, as much as we can, even in other activities, different from our activity. So basically, we were supporting in something that was not the key decision of the treatment of that patient, of course, because we are not able to do that, but still we were helping in administrative work, asking calling the relatives of the people affected and explaining if the patient was going better or worse. So because of course they cannot have any contact anymore with the patient. So yeah. And we are trying to helping in monitor the patient, but all the activities that we could do. But I think the main problem was really to know how to protect ourselves even in that period, because it was not easy to understand immediately the difference between the filtering capacity of a surgical mask, of FFP2, N95, FFP3, N99. So there is a lot with the mask with the filter on and without, with the valve and without valve. Because FFP2 you can have with and without valve, and the filtering capacity is completely different. Now we know much more, and so that's the main concern now for the phase 2, because now we are approaching to the phase 2, so we need to start again. I mean, also with not just with the emergency, with the activity that can cover different fields. We really need to have the best approach that we can have, because otherwise, if we go back, in the same situation, for us it will be very dramatic, even worse than the first one.
I just wonder if you, among your friend of colleagues of ophthalmologists who might be younger, did something happen to you all? Did did this experience happen and really change your lives working in ophthalmology and otherwise in new ways?
Yeah, I mean, this is a great point. I think we have all the facilities, to carry on to start. Okay, to start with a different approach. The telemedicine was, behind the corner, but was growing, but not so fast as can grow right now, because. We wrote a couple of papers. One is already accepted, and one is under revision. And what we found that in that paper that the telemedicine now is really the way to carry on. And probably telemedicine means so. Right now, we are organizing our department with the virtual triage, okay? That can be done, with the phone call at the beginning as a, general triage, and then ophthalmology triage. And then we can choose if the patient can go for telemedicine or for a face-to-face visit.
Yeah.
Yeah. And telemedicine will means also home delivery care.
Okay.
Also specific imaging pathway that can have, they can get with you in remote. And then, probably will be much easier in the future, even without COVID-19, to manage the patient, avoiding, this big queue that we have in the hospitals, and probably sometimes, the patient don't really need, the telemedicine is important because basically we don't have to see the patient face to face, okay? But at the same time, we can really follow the patient. I want to just for an easy example. So we need to do, for example, for age-related macular degeneration, a number of injection, okay? That is the loading phase. And then we need to see the patient to understand if they need an injection more or less. So with telemedicine, now we have the evaluation that can be done by the patient, quite precise about the reactivation of disease. And this can be done back home, okay? And in case something, is the specificity and the sensibility is quite high, we are also going with the project that to certify that, to show that this can be done. So if the patient, can at least, screen himself, with a tablet, just going through, the test that we can provide. And then, just the patient where something is changing in terms of visual acuity can get to the hospital. That is already possible, and, will be a really great improvement and helping for all of us.
So basically, you want to maintain kind of more separation due to the virus, and telemedicine is what provides that, but also in the future would continue to provide separation in environments where perhaps there needs to be. We heard many sad stories of, the many deaths that happened in Italy, and the world was with you in heart. But I wonder, did you witness that as well, or was the ophthalmology department isolated enough doing ophthalmic diagnostics and surgeries that you weren't as much a part of that?
When we knew that the situation, so by the beginning of March, we stopped completely our activity. Mm-hmm. So I cannot really tell you what was the moment when we got this really outbreak inside the hospital, but what we need to say that at the moment we want to just start with a higher safety profile.
As an ophthalmologist who's lived through this, who's worked through this, what are the more interesting things that you've noticed about coronavirus? For example, we've heard that conjunctivitis maybe could seem like it's conjunctivitis, but actually it's coronavirus. What lessons have you learned in ophthalmology?
Okay. So conjunctivitis for me is really nothing really important in the disease itself, because it's the same one that you can find in the, in the common cold or in the allergy. Nothing really. So means just follicles. So that consists in hyperplastic lymphoid tissue, but nothing really. So something a little bit different can be in the intensive care unit, because sometimes we need to go to see the patient in intensive care unit, and what we can find. So the easy findings is just the corneal injuries of the epithelium, but for that one you can just use a Steri-Strip to close the eye, or lubrificant drops. But what else? What we can find also is the central retinal artery occlusion or ischemic optic neuropathy. And this is because of this severe systemic hypotension, because of the prone positioning, because the hypoxemia due to the respiratory distress syndrome, and because of a prolonged, prone position that can be kept for, long time. So for sometimes, several days. So this is more important. And another thing is that we are also thinking about is an ocular screening program for the patient that recover from the coronavirus, because in Europe we are using Caletra, that is ritonavir, riponavir, so are two antiviral drugs, and hydroxychloroquine, okay, plaquenil, and we know that both of them in chronic, they can give this bull's-eye maculopathy, okay,
right.
But we don't know if the synergism between them also in acute can give some changes in the fundus, so in the macula.